Hello, my name is Irina Benkos, and I'm Associate Professor of Endocrinology at Mayo Clinic, Rochester. This is a video about mild autonomous cortisol secretion, or MACS. About this video, who is this video for? I designed it for patients diagnosed with MACS. Why? To summarize information on epidemiology, diagnosis, and management of MACS. Please note that information shared does not replace individualized approach to MACS. The outline of presentation, I'll briefly talk about epidemiology of MACS, diagnosis, consequences, and management of MACS. And I would like to start with an illustrative case. This is a 52-year-old woman who had a CT scan of abdomen, and that incidentally showed a 3-centimeter left adrenal adenoma. It's a benign tumor. We're not concerned at all that this is cancerous. So this is adrenal incidentaloma. What are her symptoms? She reported weight gain of 20 pounds over 3 years, insomnia, mood changes, anxiety, and brain fog. She was also diagnosed with hypertension, prediabetes, and osteopenia. Osteopenia is just another word for low bone mass, and we're concerned about it because it is associated with fractures. And on physical exam, her BMI is high. She has obesity, and it's mainly around her belly. We call it abdominal obesity. Because everyone with an adrenal adenoma has to have a dexamethasone suppression test, she had it done at home. So her local physician ordered a 1 milligram dexamethasone that she took at 11 o'clock in the evening. And next morning, she had cortisol drawn. How do we diagnose abnormal cortisol production? We diagnose it based on cortisol above 1.8 microns per deciliter. So normal is to have cortisol below 1.8 microns per deciliter if you are to take dexamethasone the evening prior. So if that cortisol is above 1.8, that confirms mild autonomous cortisol secretion. So it seems that this adrenal mass of hers right here produces cortisol in an abnormal, excessive way. And this is her complete hormonal workup. Again, she had this dexamethasone suppression test. You've seen that cortisol on the former slide. But what I would like to highlight here, that all of her other tests were normal, within the normal range. Her cortisol was normal. The pituitary hormone called ACTH that talks to the adrenal gland and makes it produce cortisol is within normal ranges. DHA sulfate, another hormone produced by the adrenal gland under stimulation of pituitary hormone, is also in the normal range. And the two tests we do to assess for cortisol excess, which is salivary cortisol and urinary free cortisol, are both normal as well. And this is actually very common in MACS. For us to see only one abnormal test, which is dexamethasone suppression test, and in fact, the guidelines do not recommend to do salivary cortisol and 24-hour urine cortisol to make the diagnosis of MACS. I also want to point out a second thing, which is despite the fact that ACTH and DHA sulfate are within normal ranges, they're on the lower side of normal. So that tells me that the pituitary gland that is producing ACTH is sensing that there is too much cortisol coming from that adrenal mass and tries to decrease stimulation of cortisol from the normal adrenal gland. How common is MACS? So we have to talk first how common adrenal adenomas are. And these are pretty common. 5% of people undergoing an abdominal CT scan are discovered incidentally with a benign adrenal mass, adrenal adenoma. And if we are to test all of these people with a 1 milligram dexamethasone suppression test, we'll actually find out that 20 to 40% of patients with adenomas would have MACS. Unfortunately, only 1 in 5 people with adenoma actually undergoes dexamethasone suppression test. So we are missing a lot of people with MACS, but that's changing and improving every day. I know we talked a little bit about diagnosis of MACS, but I just would like to summarize it again. As we are starting with an incidentally discovered adrenal mass, we have to do a 1 milligram dexamethasone suppression test. And that's when a patient takes 1 milligram of dexamethasone at 11 o'clock in the evening, and the next morning we measure cortisol, and MACS is equal to cortisol above 1.8 micrograms per deciliter. And then we want to make sure that the cortisol issue, this abnormal cortisol, is because of that adrenal adenoma and not because of other reasons a person may have cortisol issues, such as pituitary tumor-producing ACTH. And this is why we are measuring ACTH and DHA sulfate on a separate day, not the same time as cortisol after dexamethasone. And what we want to see is for these two hormones to be low normal or low. So once we diagnose MACS, and by the way, our patient does have MACS because her cortisol after dexamethasone is above 1.8 micrograms per deciliter, and ACTH and DHA sulfate are definitely in the low normal range. So after we diagnose MACS, I guess the question is, so why care? What are the consequences of MACS? And there are plenty. Patients are much more likely to have hypertension, obesity, or inability to lose weight, osteoporosis and fractures, frailty, which is sort of accelerated aging, cognitive decline. Patients frequently say that they have brain fog, abnormal sleep, mainly insomnia, but also other sleep issues, low mood, impaired quality of life, chronic kidney disease, dyslipidemia or cholesterol issues, dysglycemia, which is just another word for diabetes and prediabetes, and ultimately cardiovascular events, which include myocardial infarctions and strokes. Let's talk a little bit about management of MACS. So management decisions are actually challenging. What do we know? What happens if we do not treat MACS? We know that as a group, patients with MACS are at higher risk for weight gain, new diabetes, new cardiovascular events, and earlier death. But actually, on an individual level, this risk is variable. Not everyone gets worse. What happens if we do treat? Again, as a group, patients with MACS improve their health. They improve hypertension, diabetes, they lose weight, they feel better, and they sleep better. But on an individual level, this improvement is variable. Why? Because it is unclear whether a particular symptom, particular symptoms or health issues are due to MACS or something else. So this is why we really consider many different factors when we talk about treatment. And the most important one is patient preference. What does a patient want to do? To treat or not to treat? There are some other considerations such as age, functional status, how the tumor is looking or imaging characteristics, how bad MACS is, presence of those health issues already, and if it's a surgery that's considered as a choice for treatment, is there actually a surgeon available with surgical expertise to do adrenal surgeries? And treatment may include just monitoring and treatment of MACS-associated comorbidities or health issues in another way. Surgery is another choice to treat. Medical therapy targeting this abnormal cortisol is currently available only as a part of clinical trials, and that is an option as well. There are some additional challenges in treatment of MACS because we can sort of separate MACS in three categories. MACS because of unilateral adenoma, just like the patient I described. In this case, all abnormal cortisol is coming from this side. So this particular patient could be cured from MACS with adrenal surgery, laparoscopic adrenalectomy. But what do we do if a person has bilateral nodules? Because in this case, MACS, this abnormal cortisol, can come from both sides and not just one. So in this case, our first step, we look at how the CT scan looks. For example, if the CT shows bilateral nodules just like this, it is possible that only one of them produces cortisol and the other is completely non-functioning. And we may sometimes do adrenal vein sampling that is available only in centers of high expertise to understand whether that cortisol is coming from the left from the right or from both adrenal glands. And if it's coming only from the left, we will do left surgery. If it's coming only from the right, we will do right adrenal surgery. But if it's coming from both, we are really in the same situation as in this last example, which is MACS because of macronodular adrenal hyperplasia. We have multiple nodules on the right here and multiple nodules on the left here. In this case, cortisol is always bilateral, coming from both adrenal glands. And this is a bit challenging because removing just one adrenal gland would not fix MACS. And removing both adrenal glands would cause permanent adrenal insufficiency. So definitely a more difficult discussion and more difficult decision, I should say. So to summarize, we talked that epidemiology of MACS is anywhere between 20 and 40%, so 30% on average of all people with adrenal adenomas. We talked about diagnosis of MACS, that it is diagnosed based on dexamethasone suppression test. Cortisol should be above 1.8 microns per deciliter, and on a separate day, ICTH and DHA sulfate should be low normal or even lower than normal. We talked a little bit about consequences of MACS, which include hypertension, diabetes, weight gain, muscle mass loss, osteoporosis, fractures, insomnia, mood changes, brain fog, low quality of life. And we talked about management of MACS, which should be individualized with options including adrenalectomy, medical therapy targeting cortisol, again, based on clinical trials only for this one, or management of consequences of MACS with medications. For example, if a person has hypertension, we use medications for hypertension and so on. Thank you so much.